Jim Rollins, and I'm the Director of the Division of Items and Devices in the Coverage Analysis Group. And I'm going to talk about the coverage determination process. Even though it's labeled Medicare's National Coverage Determination Process, I'm going to be talking about the national as well as the local coverage determination process. And at the bottom of the screen, you can see the web address to get access to all of the national coverage determinations as well as the local coverage determinations. First of all, Congress has given CMS the authority to do coverage determinations and was part of the Social Security Act. And more specifically, what it says is the term national coverage determination means a determination by the Secretary with respect to whether or not a particular item or service is nationally covered under this title. And that those same words can also be used for local coverage determination. Currently, most of the policies in terms of coverage are at a local level, and the reason why is because Congress set it up that way because they felt that too much at a national level the activities would not filter out into the community and to the rest of the country. So for that reason, they set up both the national as well as local. And currently about 65% of all of our policies are local. But whether or not it's a national coverage determination or a local coverage determination, the same level of scrutiny in terms of reviewing the evidence and looking at the evidence is applicable for both. Okay. So in terms of what is covered, we cover both items as well as services. And as stated here, which, if subject to FDA review, has been approved or cleared for at least one indication. It falls within a Medicare benefit category, which is not statutorily excluded, and also which is reasonable and necessary. One of the first things that we do in terms of people approaching us in terms of developing a coverage determination is to see whether or not there's a benefit for it. If there's no benefit, there's no way that we can actually initiate the Ncd process. Also, at the very last one, it says, which is reasonable and necessary. Now, unfortunately, reasonable and necessary is not defined statutorily, but we basically define it as there's sufficient level of confidence that the evidence is adequate to conclude that the item or service improves health outcomes, is generalizable to the Medicare population, and also is generalizable to the provider community. So CMS looks at both internal validity as well as external validity. Those are important processes which helps to demonstrate the rigor of the evidence. Looking at health outcomes, that mostly addresses internal validity, whereas the generalizability to the Medicare population as well as the provider community are more related to external validity. This cartoon basically represents both diagnostic as well as therapeutic items. Essentially, those are the two realms that coverage analysis takes a look at. We look at diagnostic tests. We also look at therapies to determine whether or not a particular intervention does result in an improved outcome. If you take a look at this cartoon on the left side, basically the green represents the usual care with the usual workup, which usually results in the usual outcome. Whereas on the right part of the slide, this workup represents a workup plus a new test as well as a different therapy. And that new test as well as the different therapy can result either in the same usual outcome, a worse outcome, or a better outcome. Now, earlier, Sherry talked about quality. What does quality have to do with what we do in coverage analysis group? For those of you who are quality fans, you remember Donna Baney. And Donna Baney basically said the tenets of quality consist of three things: structure, process, and outcomes. Structure basically makes sure that the infrastructure is put in place so the patients can get access to care. Process basically looks at what it is that we do. And for a long time, in terms of quality and in terms of outcomes, a lot of people in the healthcare field basically felt that if they provided the processes or they did what they were told to do, that would result in improved outcomes. Unfortunately, sometimes the processes which were put in place were not quite as good as they could have been, so they may result in marginal outcomes. In terms of company analysis groups, we are focused on outcomes just like the rest of the organization, because we feel that better outcomes will result in something that patients desire, plus ultimately will result in a better healthcare system. In terms of diagnostic as well as therapeutic coverage, what we would like to see is that a diagnostic test provides adequate evidence that the incremental improvement obtained by a new diagnostic technology compared to its alternative changes physicians' recommendations, resulting in change in therapy that improve clinically meaningful health outcomes in Medicare beneficiaries. And that same thing can apply to therapeutics. We would like to see that the therapy provides adequate evidence that new therapeutic interventions compared to alternatives results in improved clinically meaningful outcomes in a Medicare beneficiary. Earlier, I showed you a slide which talked about reasonable and necessary. We essentially define reasonable and necessary as a clinically meaningful outcome from the patient's perspective. A lot of times we may be approached by a research group and they may provide us with some data which shows that there's some improvement in some intermediate outcome or some type of surrogate outcome, but yet they don't draw the inference in terms of resulting in some type of outcome which the patient would like to see. And for that reason, those types of studies are not quite as informative as CMS would like, because to us the ultimate outcome is going to depend on, from a patient's perspective, something that they would like to see or achieve. For example, prolonged life, decreased complications, improvement in quality of life. So those are the outcomes that not only CMS would look at, but also other healthcare plans who also have a process in place to take a look at developing policies. Now the outcomes of interest, as I said, some of them are more impressive, some of them are less impressive. The more impressive ones are longer life with improved function, being able to participate in life. Longer life with arrested decline, significant improvement in symptoms, and reduction need for burdensome tests as well as treatments. Those are outcomes which are favorable. Outcomes which are less impressive are such things as longer life, but there's a declining function as well as decreased ability to participate. Improved disease-specific survival without improved overall survival. Surrogate tests may appear better, and imaging may look better, and a physician may feel confident that what he or she is doing is improving, but unfortunately from the patient's perspective, they may not see this as being favorable because their condition has not improved or they continue to decline. Now, what prompts an NCD? What prompts an LCD? Basically, same things can occur. Currently, if there's substantial variation in LCDs at a local level, sometimes that information is brought nationally, and we will create a national policy which will trump the LCDs. Sometimes a group may approach local contractors to get coverage for a particular product, and some of the local contractors may cover it, some of them may not cover it. So you may get a hodgepodge of coverage or no coverage. If there is as I said, if there's a huge variation, then sometimes we as an organization will internally open up an NCD to make a definitive decision. Now, unfortunately for the LCD, the NCD will actually trump the LCD. So if something was covered by maybe 40 or 50% of the CMDs, and the other CMDs did not cover it, if a national determination were to come out in favor, then nationally it would be covered. If an NCD came out saying that the evidence was not sufficient, then it would not be covered, and even though it might have been covered at a local level, that no longer exists. So Sometimes we tell our persons who wants a national coverage determination that it's all or none. And sometimes that information alone will make them say, well, we would rather have 50% than 0. Because as I say, we're all data-driven and it's based on the outcomes. Sometimes we'll create an NCD because there may not be a policy. There may not be a position on it. There may not be an LCD. And even on a case-by-case basis at the local level, there may be variation. So for that reason, we may put an NCD in place. But most of the time, an NCD is going to be generated because there's sufficient evidence or there's insufficient evidence to determine whether or not something works. We're constantly trolling the medical literature. Even if we have an NCD in place, we occasionally will update that NCD because, like all iterative processes, we're constantly learning. Like other learning organizations, we're constantly trying to benefit from the vast amount of knowledge that is coming out. And so for that reason, we update our policies periodically. Also, sometimes we may get it wrong. It's possible that an NCD was written, but conclusion was drawn incorrectly. And if that happens, that information brought to us because of experts as well as others in the field, we'll take a look at that information and we will correct it if in case, as I say, a conclusion was inappropriate. In terms of the Ncd process, it's basically an open process. Starting off initially, we are approached by someone requesting coverage. Now I'm talking about things from the national perspective. We're approached by a group that may want coverage for a particular product. We will sit down with them and review their evidence. Somebody can always suggest that we create a national coverage determination, but without the evidence to drive that process, we would not open it. So if they were to approach us, they would have to bring to us information, evidence that it should be open. Now when we talk about evidence, we're not talking about consensus or anecdotal information. Anecdotal information is interesting, but it's not enough for us as an organization to initiate the Ncd process. A benefit category determination is determined, and as I said earlier, if there is no benefit category, we cannot open up an Ncd. Then CMS will actually review the medical literature. We review all sources of the medical literature. We look at all the studies, not only that are written here in the United States, but we look throughout the world. We look at a similar database in Europe as well as here in the United States. We conduct a medical technology assessment as well as a MedCAC review. Now, a technology assessment, as I said, is essentially where we take a look at the medical literature and we actually grade the studies based on an evidence-based approach. In terms of the approach that we take, we know that some studies are better than others. Some studies have a better, what we call, are more valid because there's more rigor in the design of the studies as well as the results. Other studies are not quite as rigorous. So what we would do is we'd start, as I say, using an evidence-based approach. We might look at systematic reviews, put those at the very top. And then we might look at meta-analysis, which is basically a way of combining studies together and coming up with some type of quantitative measure, which is actually able to show you a particular finding. Then we would look at randomized clinical trials, cohort studies, case series, as well as case review. Crossover studies are also evaluated, but of all the studies that we get, the ones which probably have the least amount of rigor is probably expert opinion, simply because experts are experts in a particular area. They may be so focused that unfortunately they may tend to create some blinders, so for that reason they may not be willing to change their position. They may be so invested in a particular topic that they may see things certain ways, and for that reason there may be some bias in their interpretation. But as I say, we follow that evidence-based process in terms of looking at the evidence. So once we come up with, and also we occasionally will use a MedCAC, and essentially MedCAC is a group of experts in the field, and they come and they basically provide CMS information on the topic. So once the technology assessment or the proposed is developed, then we basically post it for comments. 30-day comment, but essentially anybody can comment on our proposal. We get comments from professional organizations, we get comments from academic medical centers, we get comments even from patients, advocacy groups. So this is an opportunity for you to comment. Some people comment about the scientific rigor of the studies. Others may give us information about information which might help us in terms of making it more oriented towards the patient. So there is an opportunity for people to comment. After the 30-day comment period, we take a look at all the comments and then we come up with a final determination and then we post it on our website. So basically this is a picture which shows the entire process. As I said, preliminary discussions, and sometimes that alone will stop the process because the requester may realize that they don't have enough information to move forward. Benefit category determination, and then as I said, the staff reviews the evidence, looking at both an external technology assessment as well as a NEDCAC, and then the proposed decision memo, public comment, and then the final decision. As I said, the evidence drives the entire NCD process. We look at peer-reviewed medical journals as well as medical texts. We do technology assessment through ARC, who contracts with evidence-based practice centers who help us in writing external technology assessment, and we also use the MedCAC. And as I said, basically the MedCAC, once we engage the MedCACs, essentially what they do is they give us information on the quality of the evidence, but not on the coverage determination itself. And even though we may commission a TA as well as a MedCAC, we don't always necessarily have an NCD in mind. Sometimes we'll have an NCD and we won't use the services of a MedCAC, but we will always use the services of a technology assessment. Other times we may have a MedCAC as well as a TA, but not open up an NCD. Now, in terms of evidence, as we said, what are some of the issues? Sometimes when we're reviewing a particular topic, there is no evidence to support it. Sometimes the standards of measures, sometimes standard measures are missing. Sometimes the studies actually are short-term. Like, for example, if the patient gets a particular intervention, the studies may only follow the patient for 6 months. What about after that period of time? Sometimes there's a lack of effectiveness in terms of comparative studies. Now, recently, PCORI has been assigned to look specifically at comparative effectiveness. As a general rule, CMS, we don't look at comparative effectiveness. We can only look at one particular product and compare it to a placebo. Although sometimes we will occasionally find a study where there is some comparative effectiveness, but in general, we have not been given the authority to do that type of activity. And then the last thing, as I said, is relating to external validity. The findings have got to be generalizable to the Medicare beneficiaries. Most of our patients are 65 and older. As a matter of fact, 86% of all Medicare beneficiaries are 65 and older. So there are some patients who are on Medicare because they have disability or because of end-stage renal disease. Studies may show that something has been shown to be effective for populations less than 50. Is it applicable to the Medicare population? Not necessarily. So we really cannot generalize it to persons 65 and older. Now, in terms of a national coverage determination, this basically results in 4 outcomes. Either there's going to be national coverage, there's going to be national non-coverage, there's going to be national coverage with limitations, or it would be left up to contractor discretion. Now, let's go back to national coverage limitations. That's sort of new for us because what we've initiated over the past few years is what we call coverage with evidence development. What is coverage with evidence development? As I said earlier, if something has been found to be reasonable and necessary, it is covered. But if it's not reasonable and necessary, but if it's shown to be promising, then we can actually initiate the coverage with evidence development process. Or number 2, if the studies basically have looked at patients in a certain age group, but have not looked at persons 65 and older, then we can use that same rationale to open up a coverage with evidence development for persons 65 and older. So we're getting more and more coverage with evidence development decisions. If you look at if you've taken a look over the past few years of national coverage determinations in terms of non-coverage, the number of non-coverages have actually tended to go down. The number of coverage with evidence development has actually gone up. So this gives organizations, people, an opportunity to see whether or not that promising technology will be fruitful in the Medicare population. Now, what about a reconsideration? Once we have made a determination, as I said, periodically we do go back and take a look at the policy to see whether or not the findings are still applicable to the Medicare population, and our determination, which we determined before, is still appropriate. Now, so in order for a reconsideration to be initiated, sometimes, as I said, additional information is provided to us. Sometimes we may find it on our own, or maybe it's a national study that was produced in a reputable journal, which might actually be counter to what our current position is. That might make us that might initiate a reconsideration process. Or number two, as I said earlier, sometimes there are people conclude that the results of our findings were not consistent with the evidence, and for that reason, a reconsideration of the NCD will be initiated. So, thank you.